You're listening to Street Side, a Street Medicine Institute podcast.
Hello and welcome to Street Side. I'm your host, Michael Brennan, and this is a podcast dedicated to conversations of the intersection of healthcare, homelessness, and humanity. Today, we're thrilled to have with us Emma Lowe. She's the medical director of Street Psychiatry at Connecticut Mental Health Center, and she's also an assistant professor of psychiatry at Yale University School of Medicine. Emma, welcome to the show.
Thank you so much.
It's good to have you here, and we like to get to know our guests on the show, and I'm going to take you back. I'm going to take you back to when you decided to become a physician. When did you know you wanted to be a doctor, and what went into that?
So I think I thought about medicine all the way back into high school when I learned about Dr. Paul Farmer and global health. And I think he inspired a lot of my generation of people going into medicine and wanting to change the world, make the world a better place and serve people. That was a very vague idea at the time. But then I went to college. I went to Haverford College, where we had a really great student club called Street Outreach. And it initially was just this soup and sandwich service club that we brought like stuff to Philadelphia, to Center Circle and the or Logan Circle, and we would serve the sandwiches and soup and like talk to people. But initially it seemed like, oh, we're doing service for people on the street. That's so great. But over time I realized like, no, it's not really about the food. Like these are like pretty bad sandwiches that we're giving out, and people are coming to actually like have conversation and chat with people and tell their story. And I learned a lot about the folks out there, and I was then inspired by that. I actually studied in undergrad, I studied fine arts, so I was an art major. Although I was doing the pre-med classes, I was more interested in doing like sort of an alternative major while I had the chance, and while I had the ability to study something like really different that I would never have the chance to do again. And I was really interested in the intersection of art and the humanities with medicine and social justice. So in my senior year, I did a really long project where I painted and drew and even sculpted portraits of people on the street that I had met through street outreach. And I went with my friend who was doing an anthropology thesis at the time, and she would interview the person and I would draw them or paint them. I brought all my stuff out to Philadelphia, like painting supplies and easels and everything, did their portraits, and culminated with a big exhibition sort of humanizing the faces of homelessness of the folks that I met in Philadelphia. And then kind of fast forward a little bit to what my next step was, which I think was the critical moment of me getting into street medicine, was that I met Dr. Jim Withers at Haverford, because he actually is an alumnus of Haverford as well. He did a talk there and I was just fascinated. He was talking about street medicine. He was talking about his just kind of initially how he talks about dressing up like a homeless person and going out to the streets with his street guide Mike, and they went under the bridges and were helping people and doing wound care, and it felt like that was real, like that was really what it was about. So I asked him if I could come and shadow him in Pittsburgh, and surprisingly he said yes. And so I went for my school breaks that year, my senior year, and then he couldn't get rid of me because I was just really taken by this type of work. So I went my winter break, then my spring break, and then after I graduated, my summer break, just as a volunteer and kind of shadowing him, tried to like find a job with them, but that they weren't hiring at the time. And then eventually they were, and they were hiring an AmeriCorps position. So I immediately applied to that and luckily got that. So I was able to work for the whole next year with Dr. Withers and Operation Safety Net in Pittsburgh. And my role wasn't so much like service and like healthcare provision, because I was not even in medical school yet at that point. But I was able to kind of learn so much by just doing outreach with the teams. I was the volunteer coordinator for all the volunteer doctors and nurses. Like the scheduler, doing a lot of administrative stuff, but ended up really connecting with certain patients. And what was really interesting to me was like, I clearly had this like interest in people with serious mental illness, but at the time I had no idea what mental illness was, or, what was schizophrenia, what was any of these things. And but looking back, I now realize like those were the patients that I was drawn to and had some knack for connecting with and just engaging with them, and ended up like filling in as sort of like a case manager for these patients that were much more difficult to engage, who were reluctant to get into housing, needed extra support, would go with them to like social services to get them food stamps, would go to their doctor's appointments with them, and would visit them like repeatedly under the bridges and with the teams and form relationships, and saw many of them throughout that year then get housing. And I was like, this is just really incredible that like someone could go from what people might say is like the, I don't know, the worst time of their lives, where they're on the street, they're dealing with mental illness, sometimes addiction as well, and then this program and these resources can kind of come in and assist them to get back on their feet. And seeing each of them in their new apartments was just like so mind-blowing to me. And I realized that there's hope, like there's this, we can make change for people on the streets. And so I realized that's what I wanted to do, was I wanted to help people on the streets, make their lives better when no one else believed that they could be better. After that year, I spent some time applying for medical school. And then I once I got into medical school, I went to India actually for this time when I was waiting for medical school to start. I did a 6-month street medicine. I guess it was called a fellowship, but it wasn't like a medical fellowship. It was more of like a internship type of thing. I worked with Dr. Jack Prager on the streets in his street medicine program in Kolkata. And that was really fascinating too, because that was just a totally different set of diseases. There was leprosy, there was multi-drug resistant tuberculosis, there was vitamin D and vitamin A deficiencies that with like severe manifestations. A more public health approach was needed because there were just like thousands and thousands of people that were on the street and not having adequate nutrition, not having access to vaccines and these kinds of things. So that was really eye-opening, and getting to see like the massive sort of health disparities that existed there, and of course throughout the world. But that was just really meaningful for me, and I definitely felt sort of like I learned much more than I brought to that place. But I'm very grateful for having that experience and seeing what they do, and they're up against quite a lot of barriers and obstacles in their setting. So shout out to them in Kolkata. Then I came to Rochester. So circling back to finally where you are, and I was a medical student at University of Rochester. I was really just like, how can I get my hands on street medicine? How can I do this? And I asked around a lot. There was some idea of healthcare for the homeless. There was a healthcare for the homeless clinic, I think, connected with Unity. I asked around, and I think they weren't doing so much outreach. There was the St. Joe's Neighborhood Health Clinic, and they were mostly serving the poor and underserved, but in a stationary clinic, and had connections with different soup kitchens, etc. Managed to identify a few key people that would then later like help me create a student-run clinic or some student-run street medicine program, really. That was later called Street Outreach. Some of those people were I think the most important one was actually Hubert. And I'll talk about Hubert for a second. Hubert was a formerly homeless individual who I met through the St. Joe's Neighborhood Center. Hubert was willing to come with me and introduce me to people on the street, and I was just so impressed because he believed in this mission. Like he knew the mission from when I met him, and he knew that it was necessary, and I would just pick him up and we would do outreach together with another student. That was how it started. The U of R was aware at the beginning that I was interested in doing this, but I think wouldn't have approved at the time how much I was outreaching in my free time. But soon enough, it became official that this was a sanctioned extracurricular activity from the University of Rochester. After Hubert, we identified a few other outreach guides, people with lived experience of homelessness. We identified an attending, Dr. Lois Van Tal, who was our first attending for the program, family medicine doctor, who was always so supportive and awesome and would just come out whenever we needed her. And then it was kind of contagious. Other students started getting involved, wanting to join, and we had this very complicated outreach schedule. We were going 2 different nights a week and trying to just figure out what the problems were and engage with people out in the streets. We went to like the train tracks area, just roaming around downtown. And when we found someone, they would tell us about someone else that was sick or needed help. And there's very little that we could do as students at the time, like to deliver the care of, formal medical care. But a lot of times what we were doing was really engaging with folks and learning what it's like, what the reality is of people who are living outside and what their priorities might be. So that was so educational for me, and I think hopefully the other people that were involved in the program as well, and like carrying that on to their next chapters of their medical careers. And then occasionally we would have someone that actually accepted care or accepted housing, and we would follow them through these trajectories. And I remember one case of someone that we brought into the clinic, to the Healthcare for the Homeless clinic. Dr. Karpak was the attending at the time. This was many years ago, but she's since left. But this guy who he was on the street probably for like more than 10 years, heavy drinker, and she examined him, and he had so many issues. I felt really bad, but like it was just this like pivotal moment where like he had actually come in, and I think getting the healthcare delivered to him would be still many more months of work, and like he had Hep C, and like other specialists were needed. But then having him in the clinic, like physically there, after I had just seen him like for probably years out by the train tracks, and just like had worked on this moment for so long, and he finally came in for care. And just stories like that, where we just saw people with success stories, and like sort of moving on to housing and things like that. And yeah, I've heard since that program is still going, which is really exciting. And I know it's taken on many different forms. That was my time in Rochester, and maybe I'll stop there because I've just been rambling a lot.
No,
You can interrupt me with my questions.
No, that was fantastic, and I just really appreciated hearing your journey. And there's so much passion and commitment in your road to where you are now. I just love the way you were looking for opportunities and finding them. And I just want to raise up some points of connection between us. That my oldest son Connor went to Haverford. I think it's a gem of a liberal arts school, and just
It really is.
love Haverford. Didn't know that Jim Withers went there, so that's a nice connection. When you were talking about painting the portraits of people on the street, it made me think of a book that my wife is so excited about. It's Theo of Golden. I don't know if you've heard of it. It's a new novel, and it's about exactly that. It's about getting pictures of people and memorializing them and loving them through that. I was the clinical coordinator at St. Joe's Neighborhood Center for 7 years, and worked with Lois Van Toll. So, and I know Hubert. So we have this.
You do? Yay.
We have this nice Rochester connection here. But let's fast forward then. You graduate from the U of R, and you go into residency. Take it from there. Where'd you do your residency, and how did you stay connected to the people on the street?
Yeah, so I did my residency in New Haven at Yale, and I moved here, and really similar to Rochester, I was really looking for a way to get involved in street medicine. And I did my residency in psychiatry after realizing over the years that all these folks that I was engaging with and had a real talent for engaging with were people with serious mental illness, and realizing that street medicine also needed that facet of it. And at the time, there was not really a great following or representation with street psychiatry within the field of street medicine, which has since grown a lot. But I was really interested in how could I do the mental health component of street medicine in the street setting. And in New Haven, there at the time was no street psychiatry team, but there was a really enthusiastic street medicine team that was, already had been started and was going on for a few years at the FQHC, called Cornell Scott Hill Health Center. Their street medicine team was run by Phil Costello, a nurse practitioner, who they fondly called Dr. Phil on the street. And I figured out that he was doing this work, and I was like, I have to go find this Dr. Phil. And so I met Phil, and Phil's the kind of person who's just like, yeah, just come out with us. And so I went with him, and like just started kind of building a relationship with his team, and then the people on the street, and sort of seeing if there would be a need for a psychiatrist. And clearly there was, from his team, from the people on the street, from other entities that were in close proximity in service roles. And my residency was really supportive, but sort of was like, well, tell us, what is street psychiatry? So I kind of had to do a lot of education and explaining the background of what the street medicine movement is about. And slowly but surely, there was enough support. They said basically as long as I could have an attending and was operating within my scope of practice, then I could do street psychiatry, and I had to make it part of the curriculum. So I created an elective for myself to do street psychiatry at Yale, and that made it official. So I could use my elective time to go out on the streets with Phil's team, and that's kind of how it started. And I think what was important about both of these circumstances, just as an aside, was that I think we started with just doing outreach as opposed to extensive planning and protocolizing and things. And I think that was really important because all of that is important too. But like informing that there needs to be a street role and experience informing what the policies and practices are. So I think my process was always investigate and build rapport and understand before kind of setting the actual policies and groundwork and approvals. That really worked out because later, while I was doing this kind of just outreach elective by myself, in 2018, there was this really profound event in New Haven where about 100 or more people in 24 hours had overdoses on the New Haven Green. And it was just really made national news, looked really bad for New Haven and Yale. Like, wow, they have all this homelessness, all these drugs and all these overdoses. At the time, we didn't know what the drug was. It turned out that it was actually K2 rather than an opioid, but people were kind of passing out and having like seizure-like activity and needing to go to the hospital very quickly. And my medical director at the time, who was very supportive of this project, called me and was like, oh, there's something going on the green. Like, could you go, like, do you think you could go help? And I was like, sure. Like, what do I do? And so I brought a nurse from our clinic and a bunch of Narcan, which didn't work, but we were giving people Narcan left and right. And like mostly ambulances were just like buzzing around, like picking people up and taking them to the hospital. It was really an unbelievable scene and felt really helpless. But that event, I think, then was the catalyst for the state to take notice of what we were already doing, which was just doing outreach to people on the street and offering mental health and addiction care. Very quickly after that, we had support from the city, from the state, from Yale. Like everyone was like, "This is a great idea, street psychiatry. This could be the response." And it looked, I think, and it was like really appropriate as an intervention for addressing problems like this. Certainly not the fix, but we were very well positioned to understand the drug problems on the street and the homelessness issues, even though these were not all people who were unhoused. But it worked out really well because they hired, in that next year, they hired a program manager, they hired an LCSW, a recovery coach who had lived experience of homelessness, and then myself when I graduated residency as the attending. So in fact, that's still the same people that are on the team now. They added one additional part-time psychiatrist, Dr. Fabiola Arbello Cruz, who's an addiction psychiatrist. But yeah, we've been operating that way since 2019. Yeah, we work really closely in partnership with the street medicine team. We go out sometimes at the same times. Sometimes we just have a lot of like back and forth care coordination about the same patients that we share. We refer people back and forth, people that I see with medical issues that I might need help with, talk to Phil's team, and then vice versa. They refer people that have mental illness and that might need assistance from us. So yeah, it's a great, I guess, like story of how like a crisis can become resources in some way in the end.
Emma, tell us about street psychiatry. What is it and what are you able to do for folks on the street?
Yeah, I would say street psychiatry is about engaging people on the street who have mental illness and addiction issues, but engaging them around care. And but the care being very loose, the care meaning anything that's important to that person. I think it's very much in line with street medicine, and that's very person-centered and guided. It's not like we're going out and saying like, oh, these people seem to need extra help, we should send them to institutions or anything like that. We're much more about identifying maybe basic needs that can be met. Sometimes it starts with just giving out socks, food, granola bars, water. Sometimes we give out harm reduction supplies like clean needles, Narcan to people to make sure that they can use safely. And that process might take weeks, months, or even years of just relationship building and engagement. So I see that just to remind us that, I guess, although our expertise might be very advanced in that we can do long-acting injectables, we can do, all sorts of antipsychotics and antidepressant medications, but the fundamental part of this work, I think, is the relationship building engagement with people who have been really rejected by every system in their lives, from oftentimes failed from childhood by the child care, foster care system, the school system. Oftentimes they have history with incarceration, which has generally never been good for them, the hospital system, the housing system, all these ways that society has kind of failed them. And we're up against that. Who are we to come in and say that we have the answer for these people? So we're coming in with an attitude of like non-judgment and humility to understand what they're going through and try to help them wherever they're at. And frequently we hear in street medicine, we're really meeting people where they're at. And this is no different, meeting people really literally where they're at, under bridges, in the community, in a park, in a train station, other public places, and then figuratively with where they're at too, where we're not judging them or saying this is what would be best for you, but asking them, what do you need help with today? And how can we better assist you? And sometimes that's just really witnessing their suffering or their story at the time, or sometimes witnessing joy. Sometimes people have really exciting news and things that happen on the streets. This is certainly not a monolithic kind of story here where we see all sorts of people and their stories, and are there for them in whatever capacity we can be. And then once we have this foundation of trust, we can then start offering some kind of services, which might include individual therapy. We also do group therapy in the community. We do medication management. So we can prescribe. We can prescribe in the community, and then the person will pick it up at a pharmacy or we'll pick it up for them. We can now do injectables as well, which we would deliver, administer ourselves. And even controlled substances such as buprenorphine. We can do both the sublingual as well as the injectable long-acting buprenorphine. And we do that through the support of the Department of Mental Health and Addiction Services, or DMIS, it's abbreviated in Connecticut. That's basically the state mental health system that fully funds our program. We don't actually do any billing for the most part. It's largely state supported through the budget of the state of Connecticut, which is just really awesome, since they've considered this to be a priority. And at this time, we're the only street psychiatry program in Connecticut. But we're hoping to change that. We're hoping to expand to other places in Connecticut and offer this kind of model as a way to reach people that would not otherwise be reached, that wouldn't be able to come for traditional care in a clinic setting, that are traditionally not served by other models of clinic-based care.
You've described such beautiful interventions to try and help people, coming alongside and building the relationship and the rapport before coming up with any psychiatric diagnoses or interventions. Really love that, and it's really the spirit and ethos of street medicine. I'm wondering, Emma, you're well placed to ask this question. What is the future vision? What does the future hold for street psychiatry and let's just talk domestically in the United States? It seems to have a foothold. Liz Fry and Simon Hatcher and Kim Van Heck just wrote their book, the Street Mental Health Handbook, that got published, and it's becoming kind of professionalized, the practice of street psychiatry. So I'm wondering what your vision going forward is. What are you hoping for?
Yeah, and I agree. I have seen much more of a foothold of street psychiatry. It's coming up more in conversations with applicants for residency, for medical school. People are interested in this as a field where that wasn't necessarily the case before. I think there's more programs being started around the country. I oftentimes get contacted to advise about such programs and seeing, how did you do it here? And what are we, let's pick your brain about some questions. And so I always offer that for people to talk about how to start a program. And there's also a new Street Mental Health Coalition that meets every month on a Monday at 8 p.m. if people are interested. And that is a great way to get involved in street psychiatry. But what what I want to say about that, I guess, is that there's more and more groups that are coming out of the woodwork that maybe are doing something similar, not calling it street psychiatry, but have an interest in sort of sharing best practices. We have a lot of really interesting conversations about the future of how do we practice this, because some people are doing things quite differently, or like it's like how do we do clozapine on the streets, or do we do clozapine on the streets? And there's like conversations like that, like how do you apply a lot of really advanced kind of psychopharm in the community setting, in the street setting, and sharing how we do that with one another. I guess like I would hope, I guess, that it maybe eventually we wouldn't need street psychiatry. I hope that there were, we'd be out of a job because there wouldn't be a need for people. There wouldn't be people living on the street and in such dire poverty when there's such extreme wealth as well. But that doesn't seem to be changing anytime soon, unfortunately. But I see also, like, in the future, the hope in the trainees, because there's so much interest in this type of work in street medicine and street psychiatry, and whether or not the trainees go on to do a medical practice that involves direct street-based work, which would be awesome too. A lot of them go into subspecialties or primary care settings, clinic-based settings, wherever they might go, and they take this experience, which involves this witnessing of what it's like to be unhoused and on the street, and the day-to-day struggles, and like, why would it be hard for someone to come to an appointment on time at your clinic, and what are some of the ways that people are mistreated when they go to the hospital, and having that understanding of both sides of the story, and not just the kind of more cynical, jaded perspective that sometimes people can have when they've worked, for example, in the ED for many years, or in the inpatient setting, seeing people cycle through and not being able to do anything about it. Of course, they're going to become a little bit jaded and a little hopeless. But what I see is the trainees kind of witnessing this work and understanding that there can be better. These folks that are going in and out of the hospital, or maybe never going to the hospital, there's something better out there for them, and we can help them get that, and help them achieve whatever their goals might be.
It's challenging work, Emma, and I think we can agree on that. And there's vicarious trauma that caregivers experience, and being in solidarity with people who are maybe overdosing or not moving forward. It can just be challenging work. You've been at this for a while, and I'm wondering, a personal question, but what sustains you in the work? What keeps you going? What keeps you coming back and gives you hope?
Yeah, that's such a good question. And there certainly is a lot of difficult things that we witness in the vicarious trauma, for sure. I think I keep going back to this idea of hope, and this that I sometimes tell people the most important thing that we do in street psychiatry is believing in people. And I like to think that we believe in the people that no one else believes in, that maybe have been discarded by their own families, the systems, maybe even harmed by those systems. And we embrace them for whoever they are, whether they're, on the street, neglecting their healthcare, using drugs, whatever that might be, or maybe other heroic things that they're doing that are not recognized by society. And just we can kind of appreciate them for who they are, and help them build their lives back. And that might look like getting back into housing. That might look like having a pet and having a new purpose. That might look like reuniting with family members. That might look like recovery from addictions. It looks different for various people, but I think I've been doing this long enough to see so many success stories of people that you would not expect to have a turnaround in their lives. You might expect to just kind of disappear and like not know what happens to them, and maybe they've passed away. But when in reality, when we're able to really help someone with this intensive kind of model where we're just being persistent, going back and back and back at week after week to the same people, and bringing them in, and helping them connect to housing and other resources, we do see people really turn around their lives. And just seeing that it's a very long, like, delayed gratification. And sometimes it's like a year, 5 years to see that happen. But like, 2 of our longest term patients just got housed this month, and we're just like floored. Like, it's people that you would never thought that would ever be in a house or an apartment. And just seeing that, it just gives me hope, and like that there is if you give someone a chance, you just have to like keep believing in them, and you'll see a change, or you'll see them, rise to the occasion.
Emma, I love this. Your passion, your commitment is giving me hope, and I think it's probably giving hope to our listeners and those that are also out on the street doing this kind of work. And you just you breathe such a deep and abiding solidarity. Steadfast solidarity with those who are suffering on the street. So thank you for that. Really appreciate it. And we're coming down to the end of our time, and I usually like to give guests an opportunity to answer the question you wish I had asked. What's left unsaid?
Oh, that's a great question. I think what's something just like taking us a little bit broader, maybe into the systems that are still oppressing our patients. I just want to spend a moment on that, maybe something that's pretty prominent in the media and in many cities across the US is just this idea of encampment clearings. And we serve people in encampments. We serve people who even don't have encampments, who are just outside. In doorways or on benches. But what we see in our work is these pervasive harms that practice does. So I just wanted to mention that as one of the struggles, I guess, that this work has in it, and not only sort of making our work more difficult by being unable to find people, but just witnessing the trauma that people go through by having their lives kind of bulldozed, like more literally bulldozed at times, and their belongings discarded. And I think importantly, also setting them back from their housing. A lot of times the administrations can be very short-sighted in thinking that sweeping away the problem can at least address the complaints of certain voting civilians. But when in reality, this practice will prevent these folks from getting housing sooner because it disconnects them from case management, it disconnects them from services. Sometimes their IDs and other documents needed for housing are thrown out in the process. And so just to speak to that, I think there are things we could do better as a society to make this work go more smoothly and assist people in the process.
Stop bulldozing their tent encampments. Yeah, it seems like a basic thing that we could decide as a society to stop doing. Emma, final question. If you could do one thing to make the world a better place, what would it be?
Well, I don't want to be like cliche, but just housing. Like I think
Yeah,
I think
right.
we already know the answer. This is well studied that housing first, permanent supportive housing works, and that has been shown time and time again. There's not anything magical to it. It's just housing does help homelessness, and especially housing that has no strings attached, that is lifelong, that allows you to have a mental illness or physical illness and decide whether or not you treat it or not. But just housing first for everyone, and I think what perhaps I'll just say as a caveat, like in points for improvement in housing first are to truly make it no strings attached, to allow the person to fail potentially in that housing and still allow them to be housed. Because I think what happens sometimes is people lose that housing because of other barriers. For example, I'll just say briefly that our housing first system is primarily based on vouchers most of the time, and the vouchers need to be used in a individual apartment with an individual landlord that can sort of like evict the person for whatever reasons that are legal, but sometimes valid reasons. And if we had affordable permanent supportive housing that was managed by healthcare providers, by mental health providers, people that were trauma informed, rather than independent landlords that have no interest in this mission, potentially some probably do, but not all of them, maybe we could all align better and like have people get housing and not ever become unhoused again, and sort of better align ourselves, rather than our current system is a little bit fragmented and reliant on external factors that we can't actually control. So housing first.
All right. Love it. Love it. Emma, this has been a fantastic and delightful interview. I have so appreciated that it's been informative and inspirational. That's a nice combo. We appreciate you taking the time out of your busy life to be on Streetside. Thank you.
Thank you so much. It's such a pleasure to be on here, and I've enjoyed listening to the other episodes as well, and just honored to be part of your lineup here. So thank you so much.
Yeah, we might come back and interview again. So thanks, Emma.
Love that.
Bye now. All right. If you're enjoying Streetside, please give us a thumbs up and tell your
Street
friends.
Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.